So thank you everyone for sticking it out to the end of the meeting. It's probably all of the fellows that are going to the MIS workshop. But on behalf of the APSA and the CAPS Global Committees, we're excited to welcome you to our panel session on Bridging Borders, addressing the health needs of Indigenous and Migrant Pediatric surgical patients in North America through a global health lens. My name is Robin Petrozzi. I'm a pediatric surgeon at the University of Michigan and chair of the APSA Global Pediatric Surgery Committee. This panel session will explore the unique health challenges faced by Indigenous and Migrant Pediatric surgical patients in North America, specifically comparing patient populations that are unique to Canada and the United States and their interplay with the health system. We have all encountered these patients. We all have these patient stories. These populations often encounter systemic barriers, including limited access to care, cultural and linguistic differences, and social determinants of health that exacerbate disparities in surgical outcomes. Dr. Susie Yoder has a disclosure as a paid consultant for Holologic, and I'll turn it over to my co-moderator to introduce the panel.
Thank you, Robin. I have to admit, this is a very special way for me to end this APSA meeting because two of the people sitting right next to me are two of my prior fellows, back-to-back fellows, as a matter of fact. So it's very emotional to see them take this incredible leadership in this area, and it's just an absolute honor to be sharing this podium with them today. So thank you, Robin and Hussein, for rising to that level in such a short time and putting in all the energy to get us here. I am Sharif Emil, pediatric surgeon here at the Montreal Children's. I am the chair of the Global Partnership Committee for the Canadian Association of Pediatric Surgeons, and this is really a joint effort by our two committees. Robin happens to be also the vice chair, so she's got a foot in everything. So it is really my pleasure to introduce our speakers today. And one thing I observe and I often say about this issue that we're about to talk about is that our talk far surpasses our actions. We do a lot of talking and our actions are nowhere near how much we do. So it's very, very special that Dr. Wasanji and Dr. Hussein today are really, they don't just talk, they have done and they continue to do things that are changing the landscape for the populations we're talking about. And I just want to start with that because I think it's extremely important that we mention that at the very beginning. So my co-moderator is Dr. Robin Petrozzi. As you just heard, she's an associate professor at the University of Michigan and director of the Michigan Center for Global Surgery. And this is another theme of this session is we always say global surgery starts at home. You don't have to go all the way across to Africa or the jungles of Asia to do global surgery. There's a lot of global surgery to be done right here in our communities. There's a massive need. Our panelists really bring a diverse range of experience and advocacy. Dr. Suzanne Yoder, who is not here with us but will present by video, has put together really an incredible video to introduce the health issues around migrant patients in the U.S. She's a pediatric surgeon who works in locum tenens, including in refugee, migrant, and Native American populations, as well as in multiple international settings. She works in small team models that integrate local providers and nimbly address barriers to care, and is the founder of Single Steps International Incorporated. Dr. Samir Shaheen Hussain is one of our emergentologists at the Montreal Children's Hospital of the McGill University Health Center. In addition to his very active clinical practice, he has really been at the forefront of advocacy for our Indigenous and First Nations populations, as you will hear in a moment, and he has really changed practice. And when I say change practice, I don't mean just changed our medical practice, but changed the provincial practices, as you will hear, made a huge impact on how these patients are taken care of. Dr. Wasanji is one of my colleagues at the Montreal Children's. He completed his training in 2019. Hussein has a master's in global health from Hopkins. He is really has two huge mandates in our division. One is that he runs a colorectal center, so that's his other job, but he also has really designated his academic work, his research work, his advocacy work towards improving the care for our indigenous populations, introducing the concept of medical displacement, which I have to admit, I had never heard those terms before. He brought them to our attention, and he's done amazing work, continues to do work to address that. So without further ado, are we going to Suzanne's video first?
I have a little bit of an intro.
Okay, go ahead.
So when we talked about this session, our learning objectives were really to identify and compare some of the systemic barriers impacting these populations in Canada and the United States, to explore culturally tailored approaches to delivering surgical care to these populations, and to analyze global health principles and their application to local challenges in North America. So when we think about those global health principles, we can think about multiple various competencies. There are different frameworks when you look at the literature. I think one of the best from an academic perspective is the Consortium of Universities in Global Health. When they speak about the competencies, they have a toolkit for the competencies. This QR code will take you directly to their website with the link for those competencies. And this really is a robust concept when we think about intercultural care. Through a global health lens, the panel will discuss innovative strategies to improve health equity, drawing from diverse international and regional practices. We want to bring the patient's stories. We want to show you some action. We all have our own patient stories. So as you listen to the presentations, recall those stories. Think about how you will incorporate culturally sensitive care models, address barriers to access, and perhaps even integrate community-driven solutions in pediatric surgical care. How we address these populations is an interplay with culture, politics, economics, language. It requires safety, both physical and psychological safety. There are issues around access to care, funding, and resources, as well as voice. The voice of our patients, the voice of our providers. And so let's listen to some of those voices as we move forward.
"48 hours after crossing the border and being processed through the Office of Refugee Resettlement, my teenage patient presented to the ED with appendicitis. He was wearing the only clothes he owned, alone, in the cold environment of pre-op when I met him. His chaperone did not speak Spanish, but there was a representative from ORR who was intermittently present at his bedside who did. As an unaccompanied minor, we sought consent through his temporary custodial arrangement. Using a video translator, we explained why he was having pain and what we were going to do to help him. We explained anesthesia and surgery and took him to the OR. This patient from Honduras was lucky. He did have a known sponsor in the country who would be receiving him once his processing was complete. But on that day, he was very much alone in a very strange surrounding. While she was sometimes constipated as a baby in Venezuela, her doctors there were not concerned, and as she started taking solids, Mom adjusted her diet, and she seemed to stool regularly. The family immigrated to the East Coast when she was 2 years old. She did not have regular pediatric care, but was admitted to a hospital through the ER once with constipation. The facility did not have pediatric subspecialty care, and she had a simple clean-out that seemed to work. The family moved to Arizona when she was 4. 2 months after their arrival, they had not yet established primary care, and when she had not stooled in 2 days, she developed severe abdominal pain and distension. By the time surgery was consulted, she had responded to an enema and was playing joyfully in her hospital room. While her belly was severely distended, she was in no pain, and Mom said her belly always looked like that. After a contrast enema, she went to the operating room for a rectal biopsy and diverting colostomy to allow her colon to decompress before a definitive pull-through for her Hirschsprung's disease. While she ultimately received the appropriate care for her condition, her immigration status played a part in the significant delay in her diagnosis and care. These 2 cases highlight 2 perspectives on providing health care for pediatric immigrant patients. Homeland Security estimates that around 2.5 million people immigrate to the United States through various channels each year. It is hard to find statistics that break this down by age group, but there are more accessible data from the Office of Refugee Resettlement about unaccompanied minors. As you can see, since COVID, the average number of unaccompanied minors arriving in the U.S. each year has been over 117,000. Approximately 65% of these unaccompanied minors are 14 years or older, and 61% were boys. In recent years, most have come from Central American countries. With this tide of migration, it is estimated that 1 in 4 children in the U.S. are immigrants or have at least one parent who is an immigrant. This tool from the Migration Policy Institute allows you to look up the most recent population data by state. Information from the National Immigration Law Center outlines healthcare funding sources for these children. Those states in pale blue provide care via federally funded programs, while those dark blue states use states funds to ensure coverage regardless of immigration status. The brown states have more stringent time limit and status restraints to coverage. All of these statistics emphasize the fact that each of us as providers will encounter children and families who are working through complex issues related to their immigration status. What are those issues, and how can we best support those parents and families? Do we have tools from our global experience that may be applicable to this population of patients? The following clips are taken from interviews of social workers who were asked some of these questions. We appreciate their insights on this issue.
My name is Jyotika Acharya. I am the executive director here at St. Nick's Kids. We are a child placement agency in the state of Georgia.
Yeah, I'm Renee. I'm one of 4 of the NICU social workers here at Children's National, and I've been here for 3 going on 4 years in July.
And I'm Bridget. I'm another one of our NICU social workers. Tell me it was a family who spoke French, but he told us after an in-person interpreter came, which we have to schedule well ahead of time.
Right.
He said, "Can we request him specifically each time you guys have an interpreter for us? He's from our country. Like this actually is much more helpful for us than some of the other interpreters we've had."
Yeah.
You know, so health literacy and cultural literacy play into that transaction with language and explaining health services and things like that.
Yeah, I mean, not even the language component, but like how something translates is really, really important. But simplifying conversations to a way that the person that you're communicating with is able to understand. I think a lot of times, even as a social worker, I use words that they may be introduced for the first time, right? We use the word trauma a lot in our work, right? But what is trauma, right? It's a lived experience that may be negative to that person. But when I talk to a person and I'm asking them what traumas they've experienced, what journey that they have lived up to this point, a lot of times what one person experiences as trauma and another person experiences the same thing may not experience as trauma. So simplifying words to be able to understand what they've experienced is really, really important.
Like surgical kids, do you see, are there any unique challenges there?
I had a family very recently, and the baby had a variety of problems, but had some surgical intervention as well. And the mom, it was just very clear that like there was an education level plus the language barrier, plus she had just immigrated to the U.S. about 5 months before and was on her own.
Right.
And so all of these things kind of together, it was this situation where it's like, I'm going to very freely trust that these people are the experts in telling me what to do. But like, there was a tough, level of understanding there.
Got it.
A little bit about the actual process of accessing healthcare services for someone who may not be documented. So how do you go about advocating for them? And what are the roadblocks?
Yeah, I mean, in my limited experience, a lot of time there were a lot of phone calls. A lot of phone calls to healthcare administrators at hospitals, at clinics, just simply asking, what services can this patient get without having proper documentation, right? Enrolling in Medicaid and being able to see if, what are the out-of-pocket expenses, other immigrant populations that are documented and have, the proper immigration documents. Even those populations, when they're legal permanent residents, I've noticed that they have a harder time asking for or advocating for themselves because they think there will be negative ramifications because they're not U.S. citizens. So I think some of the immigrant population also don't understand what their rights are as legal permanent residents versus U.S. citizens, right? And so that sense of fear from not knowing and not understanding what the ramifications are, I think prevents them from asking the crucial questions they need to ask to get healthcare benefits.
One that comes up very often is babies who are born here in the U.S., but their parents might be undocumented and from a variety of different places. And so navigating one of the biggest things that comes up with those families is the parents learning how to navigate the American healthcare system with their child here. And so one of the first things that comes up is often kind of just like basic like education and knowledge of the system and how it works and what they do have access to or don't have access to. We're also in a unique position where often the mother has her own like insurance coverage for a period of time just because she has just had a baby. And so that's just kind of the context of what we often see. I would say most often see here with our immigrant families.
I think sometimes we also see that mom is here and dad is in their home country, leaving mom without a whole lot of support.
Yeah.
I think in its purest sense is just being able to acknowledge that we're not all the same, right? Understanding different cultures is a matter of being curious and asking questions and not assuming things. So I think my experience in working with such a diverse population of people is when I meet someone that is of African descent, I don't go to assuming what country they're from. I say, where in Africa are you from, right? I think, and as an immigrant myself, a lot of people, you go into a setting and there's a lot of assumptions being made before the questions are being asked. So I think one of the things that I do as an immigrant and working with immigrant populations is being able to not assume anything, ask questions, then be able to provide services to them.
Hello. Good morning, everyone. So I'm just going to talk about a few different things, actually, looking at maybe taking it a bit of a different angle on some of these issues and looking more at structural barriers around two populations in particular. So uninsured children, migrant children, and medevac caregiver accompaniment for EU or Cree and Inuit kids in Quebec. So I'll start with a clinical case, actually. So this is a case from several years ago now that was also featured in a news report. back in 2017. And the case was a case of a toddler, actually, an infant, in fact, who was actually born in Canada. And because of the parents' immigration status, was not eligible for public healthcare coverage based on various policies and laws that were in effect at the time. And when I had seen the child, she had actually been refused care from one of the pediatric hospitals in the city, and I saw the child at this clinic at Médecins du Monde, Doctors of the World, where we ran kind of a pro bono clinic for kids without insurance. Anyway, it turns out she had a massive VSD requiring repair. She was basically in congestive heart failure, and so we had to arrange for her to be medically optimized by a cardiology colleague who offered to see the child pro bono until all the paperwork could be done. In the end, all the paperwork was done. It took a while. It was very complicated, but this is kind of just was one of those kind of tip of the iceberg examples of how politics or policies impact children. So specifically in Quebec, up until September of 2021, most kids living here would be uninsured in the following scenarios. So one is if they were basically refugee claimants and their coverage expired. And then there were other provincial policies. So one is called a délai de carence, which is basically a 3-month wait that anyone has after either coming here as permanent residents, or even if they were living abroad and then coming back, or coming from a different province. If they move from a different province, there's a 3-month period where there's no provincial health coverage, and families are expected to basically take out private insurance during that time, which obviously many people cannot afford. The other category are basically babies who were born in Quebec and live in Quebec, but whose parents are not eligible for RAMQ or Quebec provincial coverage. Those babies up until 2021 were often not covered either. And then the other one is basically kids who are non-status. There's a bit of a typo with the slides, but basically it's supposed to be on a different line, but non-status kids who cannot prove, or whose parents are not able to prove RAMQ coverage. RAMQ, again, being the provincial health coverage of the that's public. And so in this context, over the years, many of us have been doing different things, and I think this is, I guess, for the newer generations too, just to perhaps highlight the importance of different forms of advocacy, not only within hospital walls, but outside of hospital walls. And so some of the things that we worked on was developing corridors of care. And so, for example, with that child that I just mentioned, having a corridor to be able to get to a cardiologist was important. There was another case, and some of these cases may seem banal, but they were really not in terms of the impacts of the children on the children. So another situation where corridors of care were important was actually a case that Dr. Emil was involved with, where there was a child who was, and this sounds banal, but it was really impactful, had an ingrown toenail. But it was, according to Dr. Emil, the worst case he's ever seen in his career, basically, because it had been allowed to kind of fester for so long. And this is a kid, too, he loved playing soccer, who was not able to play soccer anymore because of the pain that came with this ingrown toenail. So something that could have been prevented earlier on had the child been able to access healthcare got to this point. So that's why developing corridors of care have been important. And then, obviously, ending policies, now a law, actually, here in Quebec, for example, where families are supposed to pay a 200% surcharge for medical care if they're uninsured. I'm going to get to that example in a few slides. There's also the idea of solidarity hospitals, so just the idea that any hospital does not charge patients for care, regardless of their ability to pay, regardless of their immigration status. And then there are also movements for healthcare for all and status for all. The idea with status for all being that if kids can have status, then they'll have healthcare coverage, at least in the Canadian context. I know that in the US things are a bit different. And so in kind of, like I said, there's different angles that people work on these issues. And so one of the things that several of us were involved with a few years ago was basically pushing for, at the very least, children living in Quebec to be covered by RAMQ. And so I was involved in writing the memoirs, basically the submissions that went to the National Assembly here in Quebec for Médecins du Monde, but also for the Quebec Pediatrics Association that essentially were pushing for this. And as part of the Children's Without Borders working group at the Montreal Children's Hospital where I am at, several of us basically were involved in making these recommendations that the Quebec Pediatric Association took on, which this is written in French, but I'll translate. Basically, our three recommendations were basically that all kids living in Quebec be given public healthcare insurance, regardless of their place of birth or their migration status or that of their parents, to end the 3-month wait, the délai de carence, and 3 is to end the abusive practice of the 200% surcharge. Now, actually, what ended up happening is that bill passed. It was Bill 83. It passed in September of 2021, and so now, hundreds, if not thousands, of kids actually in Quebec, if they've been living here for longer than 6 months, or if they can prove that they have the intention of living here for longer than 6 months, are basically going to be covered. So all those categories I was mentioning earlier are, in theory, covered. Unfortunately, the practice has not been applied, the policy has not been applied fully in certain places, certain jurisdictions, so that's been a bit of an issue, but we are working on that. And like the bureaucratic absurdity sometimes is really striking. So what we now are starting to see, because this is only a few years old, we're now learning of children who are actually covered because of Bill 83, but when they're going to turn 18, they're actually going to lose provincial healthcare coverage because of their immigration status. So there's kind of these very weird situations as well that we're now in the midst of addressing. So I'm going to switch gears a little bit to talk about this case. It's not a pediatric case, but it's an important one nonetheless, and it's, again, one of those tip-of-the-iceberg cases. So this is the case of Kimberly Gload, who is a Mi'kmaq, so Indigenous woman from the East Coast, who was living in Montreal. This is in 2016. And she basically presented to our hospital with abdominal pain and a distended abdomen. She actually had provincial healthcare coverage, but just didn't happen to have her healthcare card with her. And so at registration, she was told that she has to pay $1,400 to access care in the emergency department. She did not have that money. She did not know her rights, or did not feel comfortable asserting them. And so basically went home. And she died 6 weeks later at home of complications from liver cirrhosis. And I spoke with the coroner who presided over her case after, and he agreed that if she had been seen at that time, it's very possible that her death could have been averted. And what's interesting and troubling, I guess, is that in a letter that she had written to her mom, but that never got sent, it was found in her stuff, she'd written, "No ID in Montreal, you may as well be an immigrant in Alabama." And this is in February of 2016 that she'd written this. So very, telling too, I think, the connection that she was able to make. And I think what this kind of highlighted, and several of us wrote opinion pieces in the Montreal Gazette and in the Devoir, so one of the papers of record here in Quebec, denouncing this, particularly because she was the victim of kind of getting caught in the crossfire of immigration policies, or policies basically that were supposed to target precarious status immigrants. She was not meant to be a target of these policies, but she kind of ended up paying the price with her life because of them. And so I think this is also important, how policies have unintended consequences as well. And so I'm going to use this just to transition, speaking about Indigenous, the impacts on policies on Indigenous peoples, and specifically of invisible policies. And this is an example of that. So in Quebec, up until 2018, there was a provincial agency that's called EVAC, Évacuation Aéromédicale du Québec, which basically was responsible for medevac airlifts across the province. And since it came into being in 1980, and since its inception, basically, it prevented parents or caregivers from accompanying their children during these medevac airlifts. And as it turned out, Indigenous kids from northern Quebec, so Cree territory and Inuit, were disproportionately impacted by this practice. I can do a 3-hour presentation on this, so I can't explain all the reasons for that, but take my word for it, that they were disproportionately impacted by this practice. And you know, we saw a lot of kids that were also, you know, surgical, obviously, trauma cases. Dr. Petrosi was involved in several of these cases back then, because she was still with us during her fellowship while we were leading this campaign. And so after trying kind of behind the scenes to change this practice, which was never written anywhere, and that's why I call it an invisible policy. It was something that was implemented by IVAC, but was never actually written anywhere. There was no written documentation of the policy. After trying to change it kind of internally behind the scenes unsuccessfully, we basically launched this public campaign in January of 2018. And there was a huge support across the province in the media and the public. Our colleagues at St. Justine got on board, the Canadian Pediatric Society got on board. One of the kind of authorities or foremost health columnists at the Globe and Mail, Andre Picard, wrote a scathing piece in support. And perhaps most importantly, many families who were directly impacted or had been impacted from this practice insisted on speaking out. You know, despite the fact that the initial government response was that they were not going to change anything. And so because of all this pressure, eventually it was actually even, you know, we were asked to write a piece for the Guardian. So this is in May of 2018. And as we continued to put a lot of pressure, unions got on board, student groups got on board, et cetera. Eventually in June of 2018, at the end of June of 2018, we basically got word that now finally there would be a written policy of allowing for parental accompaniment. And this was actually our first child whose care I think you were involved with, who basically came after falling off a bicycle, had like handlebar injuries and other things. And this was the first time a parent was allowed to accompany their child on the Challenger or Flying Hospital plane. And obviously it made a huge difference, obviously, for the family. And this family in particular, this mom had other children who had been transferred for medical care where she was not allowed to accompany them. So for her, it was night and day. For the child, it was night and day. And certainly for our trauma team, it made a huge difference to be able to, you know, find out what happened, medical history, surgical history, meds, allergies, and just having the mom there to be able to comfort the child and explain what's happening. And so I'll leave on these last two slides. So this is actually a line that was shared with me from a former pediatric resident a couple of weeks following the launch of a Hand to Hold campaign. Back in 2018. She was a resident at the Children's, and then she's now staff at CHIO in Ottawa, at the Pediatric Hospital in Ottawa. And she wrote, "I can't even recall all the times in my residency that I was in a situation where this policy affected a child I was taking care of. We knew it was the rule, we knew it was awful, and yet we just kept going." And so I think for me, for us, for a lot of us, I think one of the lessons we learned is really that when we see when we see something that's not right, we really need to do what we can to make sure that we no longer just keep going. And so I ended up actually writing a book kind of using the Hand to Hold campaign as a case study to talk about anti-Indigenous systemic racism in healthcare and medical colonialism more broadly. And in the book, there's this line that comes back on several occasions: inequalities in healthcare follow the fault lines of societal injustices. And so if we kind of look at this as a syllogism, or anyway, the correlate to that would be that so long as there are societal injustices, then inequalities in healthcare will persist. And I guess moving forward, for all of us, one thing that I think is really important is if we want to put an end to inequalities in healthcare, then we have to put an end to societal injustices more broadly. Thank you.
Okay, hi, Samir. This work is just spectacular. The policy work that he's doing is really wonderful. Hi, my name is Hussein. I'm a pediatric surgeon at the Children's Hospital. We're gonna go from macro to micro. So what do you do I'm really a programs person. If you are interested in changing things in your communities, I think a lot of these things that we do need to be from the bottom up. Samir talked a lot about policy work at the macro level, but let's just take a step back. When I was in Baltimore for some training, I thought I would go work with Doctors Without Borders and do global health. And then I realized, as I was learning about health systems, that if you really want to have a lasting change, You physically need to be in the place where the change needs to happen for years to build trust, relationships, rapport, and you can't just come and say like, let's change this, you know? A lot of you know this already, but I had to pay a lot of tuition fees to understand this. So when I came back from my master's degree, I thought that it doesn't work with my familial life and what I was envisioning for a career to move away and do like some of my colleagues have done, Dr. Puneru, to live 8 years in a different country. But I thought, who can I help here? And we have a significant proportion of Indigenous patients who live in northern Quebec. And it is quite far. And if you travel there, you'll see that it's not really different than some rural LMIC's country. So this is the northernest village in Quebec. And we are, they didn't show up, but Montreal is at the bottom. So that's 1,200 miles. What's 1,200 miles? It's New York to Miami. It's very far, very, very far. And these are patients that we serve at the Children's Hospital, Montreal Children's Hospital. And when I started my practice as a pediatric surgeon, one of my first patients came from Mistassini, which is a village which is considered Cree. Cree is one of the indigenous group in our province. And we had a policy, and it wasn't a written policy, it was a silent policy that we would keep kids for 1 week after their surgery to see them again as follow-up and to make sure everything's okay before we send them home. So if you came from Mistassini, you have to stay 1 week in Montreal. And if you came from Chibougamau, which is a non-Indigenous village, which is very close by, you can go the next day or the same day, regardless of your post-op follow-up. And this specific patient, I had done a lap cholecystectomy, very standard elective procedure. Had the patient come a week after, and the mom was really tearful. And my visit lasted, like any good surgeon, about 4 minutes. You know, everything was okay. And I asked mom, you know, what's going on? And she said, well, my sister passed. And I've been waiting for 5 days to go home so we can bury her. And this changed my practice. I was not going to do Indigenous research. This was not in my path. It was not something I wanted to, you know, take on. I was interested in programs and how you develop things. But then I thought, you know, how can we do better than this? And this is how I learned about doing the research. So this may speak to some of you who are, you know, doers, but you really need to have some data to support what you do, and that's called evidence-based policy. I'm going to be very honest. I had another patient like this, exactly the same story, that there was somebody who passed, and they had to stay in Montreal. So I learned a lot about land acknowledgement, and this is a territory in Quebec that is home to many, many Indigenous population. And I was what I learned from land acknowledgement, which I can share, is that it's one thing to put it on a slide, but you don't want it to be tokenism. And really what is useful from it is what do you do, and I know this is a loaded term, but for reparation, we had a lot of trauma with Indigenous residential school, and what do you do to make things better? And this is what I found to be my voice to make things better, is to do programs to help children who are Indigenous and have to go through medical displacement. So how does it start? It starts with a partnership. It starts with trust, and it takes years. It takes years to build that trust, and you can't just come in and say, I'm going to change your environment. And that really shouldn't be the approach. And I know most of you who are here, you have a bias to know this. But the solution is likely going to come from within, from the group, and you just have to be there to listen and translate into, you know, words that people use to build programs and policies and research papers. So regarding Indigenous research and programs, it's really nothing about us without us. And there's an OCAP principle. There are many other principles, but basically what it fosters is self-determination for the community and data that belongs to them and that they can use and leverage to get a solution that makes sense for them. So you really have to take a supporting role into this whole thing. And our role as researchers or programs developers is really to listen to patients and translate their questions into research priorities or program priorities. So how long do I have to stay in Montreal after my surgery? What is the expected perioperative timeline? This is the language that we use in academia. Do I need a follow-up? What is the likelihood of post-op complication? Can we meet by telehealth? Can telemedicine bridge the gap for remote communities? And it doesn't sound like a lot, but this change in language allows you to study it, to get benchmark, and then to start your program and to compare your program to what was done before. Because if you do any endeavor, if you don't measure it, you don't know if it's working. You might have the best intention in the world, but you have to be able to accept the data and see how you can do better. Specifically for medical displacement, this is a few things that we came across as a process to how we're going to go forward to understand how to decrease medical displacement. I'm talking about medical displacement because these kids who live as far away as Miami to New York, they have to come to Montreal. They have to come maybe for a consultation. Then the surgery wasn't booked, so they have to go back. Then they have to come back for the surgery. Then the follow-up wasn't booked, so they have to go back. And every time we keep them and we delay them. So imagine if you're a parent, you have other kids at home, you have to leave your kids by themselves or with another caregiver. You can't work during that time. You have loss of income. It's a lot of problems from a financial standpoint, emotional, and also social standpoint. So what we did is fairly simple. We looked at what was in the literature. Then we did an audit, a populational audit. What was the use of telemedicine up north in northern Quebec? We did in purple, we looked at what are the resources, infrastructure available for telemedicine. And then what we're doing right now is, and I'm learning this, is how to do patient and healthcare providers interviews to understand and listen and translate their message into not only understanding better the problematic, but hearing solutions into why is the problem as such. Is it just that you don't have access to telemedicine, or there is a cultural safety problem? You don't feel that you don't feel care is equivalent between telehealth and coming to Montreal? We need to know so we can address these issues. So these are just a few of the documents that we have prepared as part of our work. I particularly like the map, which is understanding what is available where, because you can, if you really want to do programs, you need to understand, you have to go micro. You have to understand where is the family from, what kind of resources do they have in terms of access of healthcare workers, or in terms of telemedicine. So we did a map of northern Quebec and to understand what are we dealing with. With this information, hopefully we're going to be able to move forward. We developed an agenda in partnership with elders from community, in partnership with the Cree Health Board. So there's a lot of stakeholders to go from simple, low effort, some impact to high effort, high impact, which would eventually, potentially we can do surgeries up north. We don't have to displace patients, but let's not start with that. You'll get discouraged and you'll probably fail. Start with building the relationship, building the trust, start small, get wins, and then you can accelerate and go further. So this is our humble experience with this program. I'm sure all of you have other experiences that could be very valid, and would love to learn about them as well. So thank you very much.
So those are incredible, incredible stories from here in Quebec, where APSA is hosted. Take those home to your institutions, explore some of these questions, explore this through a lens of global health competencies. We are at the end of our time, but since this is the last event, if anyone has questions, please feel free. We can probably take 2 questions for our panel, and we'll stick around a little bit after. And so a wonderful thank you to our panelists.
Hi, I'm Marcy. I'm from McGill. I'm a nurse practitioner. I work with the pediatric surgery team. Thank you for your work. I've followed your work, and it's very inspiring. My question is, how do we incorporate cultural safety and trauma-informed practice within our institutions?
Just as a show of hands, how many people are here from the US? A lot, yeah, okay. Thanks for the question, Marcy. I think it's a really important question. So I wear different hats. I don't know if people know, I mean, some people may know in the United States about what happened here in Quebec in 2020. So September 28th of 2020, there was a woman who's from the Atikamekw Nation, a mother of 7 children. Her name was Joyce Echequan. She basically came to a hospital in Joliette for care. There she was basically labeled as being drug seeking or in withdrawal, mislabeled. And about 48 hours later, she died in the emergency department. But just prior to her death, she was basically calling out for help through Facebook Live for her family to come get her because she was worried about the care she was not getting. And so she was on Facebook Live, and there were 2 caregivers, 2 health workers, who came in and basically started, yelling at her and using racist and sexist epithets against her, and that went viral. So it was broadcast basically across the world. It was covered in the BBC, in the Guardian, New York Times. And I mention that because at least in Quebec and the rest of Canada, I don't know to what extent it still has that impact in the United States, despite the New York Times coverage. There's been a big push to adopt what's called Joyce's Principle. So Joyce's Principle is basically something that was created by Joyce's family, her community, and the Atikamekw Nation as a blueprint, basically, to decolonize healthcare. And so it's basically divided into 6 pillars, including, how the public should deal with Indigenous people in terms of healthcare, governments, professional bodies, healthcare institutions, education system as well. And so there are basically kind of clearly outlined, recommendations and suggestions of what should happen, in our case, in the context of education and healthcare systems. And so there's a huge push across the country, actually, where many healthcare unions and other establishments are basically not only adopting, but looking at ways to implement Joyce's Principle, which integrates what you're mentioning in terms of cultural safety and trauma-informed care in an actual meaningful and operationalizable way. So I would encourage, people at least to, even if you're not from Canada, to at least look. It's available online, Joyce's Principle, as an example. I can't pretend to know all the different initiatives that must exist in the United States, but I do think it's a very useful one. It's also been covered in the Lancet and whatnot. So that, I think, as a starting point. But I think the real take-home for me has been, again, kind of starting from the ground up, similar, I guess, to what Hussein was saying, on the policy level, too. So in Quebec, the provincial government refuses to acknowledge systemic racism even existing. And so adopting Joyce's Principle has been very difficult top-down because one of the first statements in Joyce's Principle is a recognition of systemic racism. So what has happened as a result is that people have been organizing from the ground up. So in the education system, in the healthcare system, for even different localities to adopt Joyce's Principle, so that over time, at some point, so much of the healthcare system will have adopted it that it will be kind of impossible for the government not to do it anymore. So it's unfortunate to have done, because that basically has kind of wasted several years of our time. But I don't think it's totally wasted either, because it's kind of similar to what Hussein was saying. It also has allowed people to build relationships between Indigenous and non-Indigenous healthcare providers who actually care about these issues in a meaningful way and are trying to make that change. So anyway, we can always talk because we're both at the MUHC, but I think there are things to be done at our local hospitals that are very, very important to structurally change things. And I think the cultural safety element is really important, just in case people may not know. The idea of cultural safety came from Maori nurses out of New Zealand who basically were pushing on giving the power to patients to decide whether care is culturally safe or not. And I think that paradigm shift is very important because it forces caregivers to recognize the history of colonialism and racism that has unfortunately impacted on healthcare for many years and decades. If you want to add anything.
So I'm Jim Pierce. I'm from Central California. Our 10-county area serves about 80% Medi-Cal, which is predominantly migrant workers. Much of the food that I got actually in Nova Scotia when I was doing my fellowship were strawberries and almonds and stuff shipped out from Central California. In the last 4 months, my clinic has dropped in attendance by about 50%. Huge numbers of patients are not coming because they're afraid of ICE and ICE raids. I keep an eye to the news and the texts to find out where ICE is going because they're looking for these migrant workers. People are afraid to come and talk to us and seek health, and they're afraid of being deported from our country because of what's going on at the federal level. And it's making it very difficult for us just to hear what they say, right? You can't operate on someone if they're not showing up on the day of surgery, and you can't listen to somebody if they're not there in your clinic to talk to you. And I know you guys are involved in a lot of different projects, and I was wondering if you had any experience perhaps in areas where there's war or governments that are not interested in protecting groups of people that are medically underserved, and how we can reach out and connect with those people to hear what they need so that we have something on which to work.
I mean, I think that experience is frightening and sad, and highlights that we do not operate in our practices, separate from policy, politics, and global happenings, and that it truly is a global world. And I'm hopeful that there's more solutions, because the unfortunate sequelae of what you're seeing is going to be poor outcomes, right? I think that there's experience from around the world, but there's not a good solution apart from getting involved, telling the stories when you can. One of the reasons we had social workers interviewed is from the safety aspect of having patients give their voice, is that they couldn't, as much as we have it. So listen when you can, and advocate as best you can. So.
This is so sad, and you have a great heart. Thank you for taking care of these kids. Do they have access to internet, cell phone, or computer?
We have great shortages. As we saw in COVID, people had to go to the nearby Starbucks.
Sure.
Or, other stores were providing free internet access for the children of these communities so that they could attend school.
So if that's a possibility, I think leveraging, because you won't go beyond the fear of being deported if you come physically to your clinic, leveraging a virtual encounter could be an option, including some information on if you don't have a Wi-Fi access, you can go to these, stores for free access, and then you can have at least a virtual contact with families who really need care. And that could be a first start in regaining access to this population. You won't do surgery virtually, but at least you can listen to what's going on.
Well, I just want to thank Robin for envisioning and organizing this session, and our two speakers. I work with them all the time, but I personally have learned additional lessons this morning. So thank you all so much. It's really been wonderful to have you share with APSA and with this very faithful group of last attendance this experience. And we don't have any more sessions, so if you're able to hang on for just a few more minutes, I'm sure some people would love to come up and speak to you. Thank you all, and for those of you flying or driving back, have a safe flight back. And thanks for making this one of the most remarkable APSA meetings. Have a good afternoon.